Before introducing tonight's speaker, I need to say that the Prostate Forum of Fullerton neither recommends nor endorses the views expressed by our presenters. Neither do we recommend nor endorse the positions or opinions of individual attendees, including those individual directors of the Prostate Forum. May I also direct your attention to the disclaimer here shown on the large poster board on the stage as a continuing reminder of the position of the Prostate Forum, which is we do not give advice, we only share experiences. These statements may seem obvious to you, but in today's litigious society, it is necessary to emphasize them at our meetings. These evening talks are recorded on videotape and DVD so that they may be referred to later by our members, so that new members have access to these talks at a later date, and so that they may be distributed to other prostate cancer research groups around the nation and overseas. Because of the importance of these recordings to our outreach program, we ask that you defer your questions until the end of the talk and then come to the microphone at the side here to ask your questions so that they are audible to the entire audience, and also it will be on the recording. We also ask you either to turn off your cell phones or put them on vibrate mode. If it's necessary to use them, please leave the sanctuary quietly. Well, it's my pleasure to introduce this evening's speaker, Dr. Mark Scholz, Medical Director of Prostate Cancer Oncology Specialist Incorporated, a medical practice located in Marina del Rey that specializes in prostate cancer oncology. Dr. Scholz grew up in Newport Beach and Corona del Mar and graduated from USC in 1976. He received his medical degree from Creighton University in Nebraska. Dr. Scholz completed both his internship and residency in internal medicine at the LA County USC Medical Center, and thereafter received a fellowship in oncology, serving as chief resident in 1987 to 1988. Dr. Scholz is one of the most active physicians serving the prostate cancer community. He is co-founder and past president of the Prostate Cancer Research Institute and has been its executive director since 2006. He is also the editor of PRCI Insights, which is a quarterly full-color newsletter featuring articles from the most respected prostate cancer specialists in the country. It's a must-read for all laymen wishing to keep abreast of developments in prostate cancer treatment. I have several copies of the newsletter with me for anyone that might be interested in seeing it after the meeting. The PCRI website provides 4,000 pages of unbiased, empowering information, and PCRI also has a well-respected telephone hotline. The Prostate Forum of Fullerton initiated national conferences about prostate cancer for laymen in 1986. PCRI has continued that tradition, which we can attest is not a small undertaking. And as Murray mentioned in his announcement earlier, this year's conference will be held in September from the 7th, the weekend of the 7th to the 9th. In addition to his leadership in PCRI, Dr. Scholz has given over 60 community lectures to prostate cancer support groups about the country. Tonight's talk is an update of a talk that Dr. Scholz gave at Lou Pfeffer's support group in Whittier in 2002 regarding treatment options for newly diagnosed patients. We thought that talk was so informative and so well organized that we give a copy of the videotape to all our newly diagnosed members. But there have been many improvements to prostate cancer treatment since 2002, so we're looking forward to recording tonight's talk with our new DVD and sound system capabilities. The title of tonight's talk is Staging and Treatment of Newly Diagnosed Prostate Cancer. Please join me in welcoming again to our rostrum Dr. Mark Scholz.
Thank you. Thank you very much for having me here. I think it's good that we had it in a church tonight. As when I left my office today, I was driving down the 405 to get on the 105, to get on the 605, to get on the 91, and I didn't get very far on the 405 until I had someone next to me pointing down at my tires. And so I rolled the window down. We were going about 15 miles an hour, of course, on the freeway. And he said, "You're running on your rim." I said, "I am?" He said, "You didn't know?" Must be nice driving a BMW. And then he sped off. And so I pulled over to the side, and indeed I had a flat tire. But I'm proud to say I had it changed in 10 minutes. And the traffic was pretty much wide open the rest of the way. So that was a miracle. And I attribute it to the fact we're doing this in a church tonight. So I got here a little early, went down to Starbucks, and reviewed my talk, and it was very peaceful. So thanks again for having me tonight. This is a topic that that of staging prostate cancer that's very dear to my heart, because I think a lot of the confusion that is out there about prostate cancer has to do with the fact that people don't realize that prostate cancer is a variety of different illnesses at different stages. And what's confusing is it's all called prostate cancer. They don't give it different names for these different things. So tonight we're going to try and go through and subdivide it. That's the first part of the talk. And the second part of the talk, we're going to talk about a newer form of treatment that's come out recently called active surveillance. So let's get started. So I was just mentioning to you that there are a number of varieties of prostate cancer, and they can range from being so indolent that they don't need treatment to being so aggressive that we should be giving not one treatment, but 2 or 3 treatments simultaneously. So picking people for these things is obviously very important, because the more treatments you give, the more side effects you get, and you don't want to be giving treatments with side effects unless it's really, really necessary. I want to give you a couple examples of the type of variety that we see. A patient that I saw starting in 2001, relatively young man, he was in his 50s, diagnosed with Gleason 8 disease. As we know, that's a high-grade type of cancer, worrisome, and he had surgery, as many men do, and they found out that the cancer had escaped into the seminal vesicle. That's a little area of the prostate just outside the gland, but it's a worrisome sign. He went on hormone therapy, and after only 12 months, his PSA started rising, which is unusual with hormone therapy. Hormone therapy usually has a lot more durable effect. And within 3.5 years, he died of prostate cancer. There's another gentleman diagnosed quite a bit earlier, also probably in about the same age, but now older now. And he had a Gleason 9 high-grade cancer, had surgery. It was in the seminal vesicle. Cancer came back afterwards. He also went on 12 months of hormone blockade, stopped the hormone treatments, testosterone returned, and his PSA has never returned. And he edits our prostate cancer newsletter to this day. So 2 similar pairing cases with completely different outcomes. What is going on? It doesn't seem like we're dealing with different stages of the same illness, because there were a lot of similarities between those cases. Sounds more like we're dealing with 2 different types of prostate cancer. So this is an important principle that we need to be thinking about, is that there's types of prostate cancer, and then there's stages too. So you can have early or late stage, then you can have more aggressive, dangerous types, and you can have more indolent, low-grade types. Why is this important? As I mentioned before, you need to be picking the treatment that is tailored for the degree of risk represented by the disease. And also, this helps doctors tell people, what to expect. What kind of arrangements do they need to make? It develops a prognosis for people. So these fundamentals are essential before you get started with treatment. So the threats then from prostate cancer are not only missing an opportunity to cure someone, but the other threat that isn't talked about as much is giving too much treatment to someone and making them ill from treatment even when they didn't need that much intense therapy. Now this is probably the most complex slide, and this is just kind of show you the complexity behind some of the principles I'm going to share with you tonight. This is not, this is in its rough form. This is kind of starting a level below, and we'll coalesce this into some simpler principles for you to grab a hold of. But these principles here also, you'll see, make sense. The kind of things that are going to affect long-term outcome with prostate cancer, and perhaps any type of cancer, will be how much cancer there is. Are there a few cells, or are there many cells? Has the cancer grown into a large number of cancer cells? It'll be the grade of the cancer. This is oftentimes signifies how likely is it to spread when we talk about grade. So you can have a cancer that grows fast but doesn't spread well, or you could have one that grows slowly but spreads early, right? All these are different variables to be taken into account. Then we have the actual stage of the disease. How far has it gone in terms of getting outside the prostate and then into other parts of the body? The growth rate, as I mentioned, if it's growing quickly or slowly, is a very critical thing. And then the last item to be considered is how well does it respond to treatments. You can imagine that you could have a lot of bad outlook, and if the treatment works well, that tends to trump all the other factors. Prostate cancer is kind of unusual that it tends to spread sort of sequentially from the prostate gland, which is, as you see indicated on this picture here, out into lymph nodes and then later into bones. What's thankfully somewhat unusual about prostate cancer compared to other cancers, it doesn't usually spread to the liver, to the lungs, and to the brain like some of the more dangerous types of cancer. Now, before we go into the type of methodology that I'd like to share with you for looking at different types of prostate cancer, let's look at the methodology that's out there right now and the strengths and weaknesses of that. Anthony D'Amico is a brilliant Harvard researcher that has done a lot of work showing how to separate more dangerous prostate cancer from less dangerous prostate cancer. And his system is being accepted pretty widely in research circles, and it's oftentimes used for helping counsel patients. And this is how it breaks down. He breaks it down into low, intermediate, and high-risk prostate cancer. And you say risk of what? Really what they're talking about is risk of spread, or risk of relapse, or risk of dying, okay? So low, intermediate, and high sounds a little bit vague, but you can imagine there's a difference, and knowing which category you are in could be useful. And you can see the way it breaks down. You're probably familiar with this terminology. The grade, if it's less than 7, or greater than 7, how high the PSA is, and of course, if there's a bump that you can feel in the gland, how big is it? So low risk means that all three of these categories are favorable. Intermediate means that they're all favorable except for one or more of these. And high means that you have any one of these, you're high risk. So this has been a useful development over the last 10 years, but there are limitations with this staging system because as time goes on, we get new information about how prostate cancer is going to behave over time, and that new information hasn't been incorporated into the Anthony D'Amico staging system. So some of the important factors are how fast the cancer is growing. It may seem funny, but it was only in the last 5 years or so the doctors realized that the rate of rise of the PSA is important. It took us 18 years to verify that rather obvious fact when you think in retrospect. But another thing that Dr. D'Amico came up with is if you look at how many core biopsies have cancer in them. Usually people have 6 to 12 core biopsies taken. Clearly it's going to be worse if all 12 cores are involved as opposed to only 1 or 2. The response to treatment, and I'll come back to this, but how low the PSA goes once people are put on hormone treatments or other therapies. And of course, a rather obvious one is there cancer in the lymph nodes? I mean, that's clearly a bad thing, but the D'Amico staging system doesn't really allow for the presence or absence of lymph node involvement. Now, another weakness of the D'Amico staging system is it doesn't divide men into groups that specifically push people towards different types of treatment. It doesn't, one could say, well, with a low-risk group that I showed you before, I guess we can go back for a moment, the low-risk group that, you know, you're going to use little or no treatment, and in high-risk groups, you're going to tend to use at least one, maybe two treatments or more. But this is a complete mishmash. No one really knows what to do with that group. So it hasn't been as useful as it could be because it doesn't allocate people towards specific treatments. For example, Dr. D'Amico himself reported in the New England Journal of Medicine that if you took a group of low-risk men, 900 men, 700 here and 213 here, who had surgery, and if you look back over time, to a year or two prior to the surgery, whether their PSA had jumped more than 2 points, indicating the cancer could be growing quickly. But otherwise low risk, low Gleason 6 or less, PSA under 10, no big bumps on the prostate, low risk, except the PSA jumped 2 points the year previous. Within 7 years, 7% of the men that had had more than a 2-point jump in PSA had died. I mean, low-risk men with prostate cancer aren't even supposed to die within 10 years, but 7% of these men had died. Whereas those that had less than a 2-point, these people did behave like low-risk patients, as we would expect, no mortality within 7 years. So that's a real weakness. Here's another one that also Dr. D'Amico reported in the Journal of Clinical Oncology. Let's take an intermediate risk group. You may remember that's someone that may have a Gleason 7, a PSA of 10 to 20. But if you divide them by how many core biopsies are involved with cancer, say a third of the core biopsies versus more than half of the core biopsies, this is the relapse rate after surgery. If people had an operation and more than 50% of the core biopsies were positive, practically 100% relapsed after surgery. Whereas if less than 3 were involved, practically no one relapsed after surgery. Wow. That's a pretty powerful indicator. It's not in the D'Amico staging system. So what's needed, of course, is to incorporate this powerful new predictive information into a staging system. And the way we think the sensible way to break it down is into 4 categories for men. And the categories, I think, make sense. We'll go into more specifics in terms of how you allocate men to these categories. But first, a group of men that are very low risk for spread. The good risk in all senses, not just D'Amico good risk, but low rate of PSA rise, favorable core biopsies, and other factors. People who have group 2 would be people who have a substantial risk for some microscopic spread, but despite intense efforts, there's no proof anywhere that it has spread. The PSA may be up, the Gleason score may be high, but there's no established cancer outside the prostate. Group 3 is the people that do have established cancer outside the prostate with a scan or a biopsy or something of that nature, but short of either having bone metastasis or being resistant to hormone treatments, which would be category 4. So if you look at these 4 groups, how do we identify men? Well, it's built on the D'Amico information. So a category 1 person, that would be the people with localized prostate cancer. We're looking at everything favorable, a Gleason score less than 7, less than a third of core biopsies positive, and no single core more than 50% replaced, a small nodule or no nodule on digital rectal exam, PSA less than 10, and a PSA density, which we'll define later, less than 0.15, has to do with the ratio between PSA and the size of your prostate. Obviously, the PSA has to be rising less than 2 points a year, and some sort of imaging that does not show any evidence of spread through the capsule of the gland. The men that have substantial risk for microscopic spread would be people that have higher grade Gleasons, more than a third core biopsies, PSAs greater than 10, or fast rising PSAs, or a bump in the prostate that involves more than 2 of the 4 quadrants of the gland. So you're talking about a fairly large palpable nodule. Category 3 would be people that have established spread into the seminal vesicles, lymph node spread. There's an old blood test called prostatic acid phosphatase, which doesn't usually indicate much, but when it's elevated, it's a very strong indicator for spread outside the gland. And also, when you put people on hormone treatment, if the PSA doesn't go all the way down, I'll come back to this nadir issue, that is also a very worrisome sign. So, in fact, here's the data indicating that. This is a graph looking at about 160 men who went on hormone treatment for at least 8 months and then were watched for up to 10 years down the line for whether or not the cancer ultimately spread into the bones, which is, as you know, a bad indicator. And they were just divided out by whether or not their PSA got down to this level, 0.05, in less than 8 months from starting the hormone treatments. And if they did, their incidence of getting bone metastasis over the next 10 years was about 5%. However, patients that went on hormone treatment for 8 months and their PSA could never get this low, 85%, 90% had bone metastasis within 6 years. A failure to respond to hormone treatment is a very worrisome sign. And this is why these men are in category 3, even if everything else looks good. If their PSA is low and their Gleason's low and all these things, if it can't get down to this level, that's a high PSA nadir and a very worrisome indicator. Now, category 4 is fairly standard, bone metastasis. Some people don't know you can also find bone metastasis with MRI or bone scans. And then hormone resistance. If people have a rising PSA while they're on Lupron or one of these drugs and the testosterone's proven to be low, that's a category 4 patient. Okay, now does this sort of category separation really indicate what the future is going to bring? And I would argue that the answer is yes. If you look at the category 1, the survival, more than 100%. Now, we don't know how to do math around here. That's more than 100%. Well, how do you get more than 100%? Well, they're comparing the survival of men with category 1 with people who have never been diagnosed with prostate cancer. And it turns out, if you take similar aged men who've never been diagnosed with prostate cancer, they have a higher lower 10-year survival rate than men with this type of cancer who have been diagnosed. How can this be? Well, first, obviously, the mortality from category 1 prostate cancer is essentially negligible within 10 years. But the difference is that the men who have been diagnosed with prostate cancer are seeing a doctor. And it's been clearly shown that having some medical intervention in your life, getting a stress test, having your cholesterol checked, watching your blood pressure, blah, 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 is going to reduce your 10-year mortality compared to people that aren't seeing the doctor, basically. So that's why men with category 1 disease actually have a greater than 100% survival compared to men in the population who've never been diagnosed with prostate cancer. Now, category 2, these are the men that have suspected microscopic spread but not proven. There was a study in the New England Journal published in 2005 where I think it was about 100 men volunteered who had surgery and they found cancer in their lymph nodes. I'm quoting the wrong study. This is a comparison between men who had no treatment. This was done in Europe, and I'll be coming back in detail and talking about the Bill Axelson study. This study is probably the most important study that's been published in prostate cancer in the last 10 or 15 years. So we'll come back and go over it in detail. But basically, the 10-year survival in this group of people, they had category 2 disease, was 90% if they had surgery and 85% if they had nothing. They just sent them off into the sunset and said, you're not getting treatment. Category 3's 10-year survival depends on how quickly people get on hormone treatments. And this was another study published in the New England Journal of Medicine. This is the one where the people had surgery and they had shown that the cancer had spread into their lymph nodes, all 100 men. And then they volunteered on a randomized basis to either take immediate hormone treatment or to wait until the cancer got into the bones. And the 10-year survival was vastly improved by getting on the hormone treatment right away compared to waiting until it got into the bones. Now, I don't know why they have to do studies like this. I mean, it sounds absolutely inhuman and unethical, but this is the way researchers think. So this was the difference in survival, but you can see getting on hormone blockade early, even though it was proven to be in the lymph nodes, surgically proven, almost a 90% 10-year cancer-specific survival. Now, what if it's in the bones? Well, historically, about 1 out of 10 men lives 10 years. And this is, now what are we doing now that we've got newer, better treatments? We don't know. A lot of new treatments have come out in the last 3 to 5 years. But the historical outcome has been very, very poor with proven spread into the bones. Okay, so now I'd like to try and match these different 4 categories to some general recommendations about what kind of treatments should be considered. I mean, what's the point of staging if it doesn't lead you to some general sense of what do I do about it? So we're going to briefly go through, well, a little more than briefly, go through the different options based on these different categories. Now, I'm going to quickly jump over treatment for category 1 and just give you a couple words, because I'm going to come back at the end of the talk and address this in more detail. But basically, as I pointed out, the survival in these people is greater than 100%. So the recommendation is to watch it closely and don't treat it unless it starts to grow. This is called active surveillance. People who are in this category need to not be concerned about prostate cancer death. They need to be worried about dying of heart attacks. They need to be worried about overzealous therapy that's not needed. They need to worry about something being missed. You know, you do need to do the scans and the PSAs and whatnot, but they don't need to be worried about dying of prostate cancer within 10 years. Okay? So the advantage of this, of course, is no direct side effects. As time goes on, better treatments are coming out. And I've found that many men, when they get a wake-up call and says, oh, there's a little prostate cancer in there, many will change their diet, start exercising, see the doctor more frequently. It can actually be a favorable thing. So I'm going to jump on now to category 2. Category 2 is the longest and most complex discussion about what to do. In fact, all I'm going to leave you when we're done with category 2 is a list of options, because the evidence that one of these treatments is better than the rest for making people live 10 or 20 years doesn't exist. We know that they all are probably helpful and perhaps in a similar quantity, but there are no good comparative trials. So all we can do is say these treatments are here and look more at the side effects of the treatment and try and pick the least toxic one. So I'm going to start first by talking about some sort of hormone blockade, what we call testosterone or TIP, and then also discuss the standard treatments like surgery, seeds, radioactive seeds, IMRT, a form of beam radiation, partial cryotherapy. And of course, as men get older, for an 85-year-old man, one could consider active surveillance in this risk category, but I'm not going to go into that in much detail. First, let's talk about testosterone blockade. We were looking at that one study where I said that if you had lymph node involvement, you had an 87% 10-year survival versus only 59% if you waited for hormone treatments. Well, that was for category 3. Well, what about hormone treatments for category 2? If it works well in men with proven lymph node involvement, won't it work better if there's less cancer? Well, there's several reasons to believe that it will. These medicines have the advantage of working throughout the whole body. So if there is some spread, it can attack cancer in the bones and the lymph nodes, which surgery and radiation can't do. The side effects wear off when you stop the treatment. As I mentioned before, looking at how the PSA drops on treatment gives you an idea of what the future is going to bring in terms of the PSA nadir. And we've taken it a step further, and after 12 months of treatment, we will re-biopsy the prostate and see how much cancer is left. Our preliminary studies in this area indicate that about 2/3 of men have clear biopsies after 12 months of treatment. And there is some synergy if people get into this type of treatment and they don't like it or they want to stop early. Usually it sets the table well for other treatments like radiation or seeds because it makes the prostate smaller. So it doesn't burn any bridges, and it may even help some of the other treatments if you decide to switch therapy. Now, this type of treatment's been called a lot of things: testosterone blockade, androgen deprivation therapy, hormone blockade. It basically consists of medications. We recommend medicines from each of these 3 groups, one of these, and one of these. And we call it testosterone inactivating factor, or TIP. And this constitutes TIP. But this is basically the same thing as these other things. And the terminology has been in flux for years, and no one's really settled on one name. The program that we use for giving testosterone blockade is to first stage the situation accurately, get a baseline ultrasound, and then we administer the treatment for 12 months. Then we repeat an ultrasound and biopsy to find out if the cancer's gone away or not. If the repeat biopsy shows that there's still cancer in the prostate, we consider treating it with some additional therapy, perhaps a seed implant or radiation. And if the biopsies are clear, we tell the patients that they can consider going just on active surveillance and stopping treatment. Obviously, if the PSA doesn't drop low, we don't talk about just stopping treatment. We talk about greater intensity of treatment. And men, in our experience with this type of approach, in the early years, we didn't even do biopsies. We just stopped therapy and watched people. And about a third of the men have never needed a second treatment. A third of the men had the PSA rise rather quickly, and many of them migrated on to a seed implant or IMRT over the next 3 to 5 years. And another third of the men in this study that we looked at, the PSA slowly came up over a 4 to 8 year period. Many of those individuals elected to take a second course of TIP to suppress the PSA again. The side effects of this type of treatment are substantial. This is a list of all the potential side effects of TIP. The ones in green, I make them are less threatening because the types of things that you can do to counteract them are darned effective. So most of this, like breast growth, for example, sounds horrifying, but these pills prevent it. So as long as your doctor's on the ball and doesn't wait till you already have a C cup and then thinks about treating it, then you can, you'll be okay. So you have to have a doctor that's on the ball and on the lookout for these things. I can't tell you how many times I've seen men come in for a second opinion that have been on Lupron for 8 years and no one's ever done a bone density test on them. And we know that men lose 10% of their bone density the first year of TIP. So, but it can be prevented. These medicines are very effective in sustaining bone mass. But they're not on the treatments. The doctors are not paying attention. So now the ones in yellow, these are a little more problematic. There are things to be done, and they have variable success in different individuals. I put them in yellow because rather than taking a pill, I mean, a diet. I've got to eat less to not gain weight. Yes, yeah, absolutely. People that just stay on their diet with hormone treatments will oftentimes gain 10 to 20 pounds. It's going to be a real serious problem, especially if they have some pre-existing blood pressure problems, pre-existing diabetes. So diet, not a very fun proposition. This tiredness issue is related to this muscle loss. I don't know how muscle loss got into this up here. Resistance training should have been down here. Lifting weights to prevent muscle loss is one rather tough row to hoe. I mean, that's not pleasant. It works, but you have to be serious about it. And then, of course, here in red at the bottom, well, this is the very thing we're blocking, right? Basically, there is no treatment. While men are on TIP, they have no sex drive. This doesn't mean impotence. Impotence is the loss of ability to get an erection. With the miracle drugs out there, men can get erections. But while on testosterone deprivation, on TIP, most of them could care less. And that is a major problem. So this is not something to be toyed with. But of course, as we go down and look at the other options, we're going to see that none of those are fun either. So this is this category 2 group is a choice amongst a lot of pretty unpleasant options. So let's go through the other 4 common treatments that are used the idea of these treatments is to get the cancer before it spreads. That's because obviously surgery doesn't take care of a cancer that's already in the lymph nodes, or a seed implant it only takes care of the cancer that stayed home in the prostate. So it's like a preventative thing to make sure it doesn't spread in the future. And we'll look at a study at how well it does that down the line, but these are standard things that are commonly done. So let's kind of look at them all in terms of the pros and cons with each one of these compared to the other options. For example, the advantages of surgery. Well, when you cut the gland out, you can take it into the laboratory and fine slice it and look at the gland under a microscope. And for the first time, you can really know, did it spread through the capsule? Is the whole Gleason score that was seen by needle biopsy really representative of what's in the gland? So that's an advantage with surgery, and that's not available with any of the other options. Another advantage with surgery is you may all be aware that PSA is produced by the prostate gland as well as by prostate cancer. Surgery removes the gland, taking away all the background noise from PSA. So if a person has an operation and the PSA goes down to 0 and subsequently the PSA starts to rise even a little bit to 0.1, 0.2, you can just about take it to the bank. That person has recurrent cancer. Now with radiation, because the gland is left intact, the PSA has to rise up to 2 or 3 or 4 before the doctors are convinced the cancer is back. So advantages of surgery, additional information about the cancer stage, and PSA recurrence are detected earlier. Disadvantage, it's surgery, okay? I'm not going to say any more. That's a disadvantage. Impotence, 50% of the time in skilled hands. Incontinence, 5 to 10% of the time. Scar tissue and keloid formation, where they reconnect the bladder and the urethra, can cause blockage and problems there. And penis shrinkage, it's not talked about very much, but almost all men that have surgery have some degree of penis shrinkage. So let's look at seed implants. How do they compare? Seed implants are attractive because they can be given in one quick outpatient 45-minute procedure under spinal anesthesia. It's done. Men can walk out after the anesthesia wears off, go out, have dinner with their wives, and the treatment is behind them in terms of the actual administration. Potential side effects can come later, but the treatment's done. So the cure rates look easily comparable to that of surgery. There's no disadvantage there. And the nice thing is that the radiation, because the seeds are put inside the prostate, is not scattered all around the body. So it's just in the area you want it to be. Disadvantages, impotence, similar to that of surgery. A condition called radiation prostatitis, where the inflammation from the radiation causes urinary problems that are very similar to a urinary tract infection. And in maybe 10% of men, it goes on for a couple years. Okay, 1 out of 10 men. Following the PSA afterwards, after surgery, simple. After seed implants, sometimes the PSA does these artificial hops. Scares the heck out of everybody. And if you watch these, sometimes it goes down without any reason at all. So we're watching PSA closely to see if men are going to relapse, but seed implants can cause a bump in the PSA that can be confusing at times. And then lastly, not every man is a candidate for a seed implant. Some men have prostates that are too big, or they have a lot of pre-existing urinary problems. So it's not for everybody. A lot of men are candidates, but not every single one. So what about the newest form of beam radiation called intensity modulated radiation therapy? Beam radiation was something we never recommended in our practice throughout all the 1990s. Too high rectal burn rates, too low a cure rates. But now that has changed, and a lot of people aren't aware of that. It's still called radiation. We all know what radiation is. Just forget that stuff, right? But I'll have to tell you that scientifically, the technology, and I'm not a radiation therapist, the technology with radiation has been really turned around because of computer aiming and just a rapid advance in this field. So it compares with cure rates with surgery easily. Cure rates are at least as good as surgery. And most people who we refer around the Los Angeles area for this treatment, because the treatment goes for 8 or 9 weeks, that's in the disadvantage column, complained that the West Los Angeles traffic was the worst part of the treatment program after it's all said and done. Now, there are some symptoms of irritation to the rectum in some people, or some with mild urinary burning, usually. Some tiredness that can last for a month or 2, but usually it's not bad. Of course, with all these things that destroy the prostate, the numbers are pretty much the same, about a 50% incidence of impotence. And the rectal burn rate now was 30% in the 1990s. That's why people have the willies when people say radiation. But now they've got it down around 2 to 4%. If you're in the 2%, you're not really that thrilled about the other 98%. But it is a much more plausible way to go than it used to be. And it certainly needs to be on the list for consideration. Men with IMRT can get a rise in PSA, artificial rise in PSA like seed implant patients, but it's a lot less common and usually not to the same degree. Now, cryotherapy has been around for about 15 years, and they've worked out all the nuts and bolts of it, but it's never jumped to the top of the list because when you freeze the whole prostate, it almost universally causes impotence. And surgery, seed implants, IMRT, I said it's only about a 50% risk. Well, it's not exciting, 50%, but it's better than 0. So full cryotherapy is maybe something to be considered in an elderly man or whatnot. I'm not going to really put that on the list as being a competitive option, but I think partial cryotherapy, where they go in and attempt to freeze just where the cancer is, not the whole prostate. Less side effects and probably a darn good chance to cure it. So what the advantages of this is that it appears, with very preliminary studies, that the incidence of impotence is going to be less with freezing just part of the prostate rather than radiating or operating on the whole prostate. Problem is that there's probably only 300 or 400 men that have been through studies that have documented. They're suggesting the impotence rates are around 20%. In my experience, the problem with preliminary studies is that the doctors doing this are real excited about it, and they tend to hear the good news and forget the bad news. And many times these rates will drop as the studies go on over time. But right now they're reporting about a 1 in 5 impotence rate. I hope it holds up. The reason that cryo can be considered to be used in this fashion is because it's the only one of these options that you can go back and do again. You can't do a partial seed implant or a partial surgery because you can't go back and do another seed implant or another surgery. So if you don't get it all, you're screwed, right? But with cryotherapy, you can go back and repeat it a second, a third, or a fourth time. So you have a backup plan if the first go-round didn't work. So since we're only freezing part of the prostate, we don't know yet, but one might speculate that the cure rates may not be quite as good as seed implant surgery or IMRT. But there are, again, no comparative studies. Preliminary small pilot studies are intriguing, and I mention it because none of these options are attractive, and this is a hopeful possible embellishment of the options that are out there. So that was category 2. Category 3, you may recall, are the men that we know there's cancer outside the gland. It's not suspected. We're not worried about it because of a high Gleason score or a PSA that's up. We know it. It's based on a scan or a biopsy. Those men, as I showed you before, these men have an even higher risk of dying of prostate cancer and therefore should get, in my opinion, combination therapy. Starting on testosterone blockade, probably going for about 18 months, and then not only radiation therapy to the prostate, but to the lower lymph nodes down near the prostate to try and catch anything that may have jumped to the first stage. And then possibly consider a new form of chemotherapy that has been shown to prolong survival in men with advanced disease. Some of the big changes that have happened in all cancers over the last 20 years has been taking medicines that are proven to be active in someone with really advanced disease and trying to move it up in the earlier stages to leverage the treatment and make it more active, believing that you're going to get more bang for the buck treating a little bit of cancer than you are against a whole lot of cancer. So that is called adjuvant treatment. This is like breast cancer patients who have a lump removed and then they have radiation to the breast. And then they get 4 months of chemotherapy. What they're thinking is, well, maybe there's a speck of cancer out there that we should treat. Well, in this case, of course, the group of men I'm talking about, we know there's cancer out there, right? And we know in that one study that there were 10 or 15% of men, even though they had hormone blockade, they still died within 10 years. Probably because there were some hormone-resistant cells from the get-go. Can this type of medicine eradicate the hormone-resistant cells in some cases? We're hoping so. Studies are in progress. The treatments have side effects, but they're usually manageable. And so this is something that has to be presented to men on an individual basis because, as of yet, if there is a benefit, and there probably will be, we don't know how big a benefit it is. So if you look at the side effects, this is what the ticket price for admission to this concept. This is usually medicines given for about 3 or 4 months. The medicines cause reversible tiredness and some achiness. You can have temporary hair loss, some numbness in the fingers and toes that slowly resolves over time. And then there's other side effects that can be counteracted with expert medical care. Thank God these days that things like nausea, which used to be a common side effect of chemotherapy, which is what this is, are pretty much eliminated with different methodologies. So the main side effect that you worry about is the tiredness that comes after each treatment. So what about category 4? How do we treat those people? Well, these are the men you may recall that have proven spread into the bones or who have started to become hormone resistant. One of the basics, there's a lot of things that are going to be presented on this at the upcoming meeting in 2 weeks that was mentioned before. But just briefly, the idea is to not use just Taxotere, but to combine it with a variety of other active agents that supercharge Taxotere, that increase the activity. For example, if you give this medicine by itself to men with cancer in their bones, not just a little bit of cancer in their bones, you probably get a benefit in maybe 1 out of 2 or 60%. If you add this medicine, a new FDA-approved product for colon cancer called Avastin, to the Taxotere, about 90% of the men benefit. This is a rather amazing breakthrough drug. They're studying it in prostate cancer to prove that it's, works so that they can get FDA approval. But right now, this is on the market, and if you are in this situation, you should be talking to your doctor about possibly adding some Avastin. Now, these other products also improve the Taxotere. So the art these days is figuring out how to combine these and get the maximum benefit out of all these agents. So let's just review. We're coming to the end of our staging part of our talk. Instead of the D'Amico low, intermediate, and high-risk staging system, we're proposing category staging into 1, 2, 3, and 4 categories based on more or less taking the low risk with refinements from D'Amico for Category 1. Category 2 incorporates D'Amico intermediate and high risk plus men that have fast rising PSAs or more than a third of their core biopsies positive. Category 3 men are the ones that we know it's in the seminal vesicles, know it's in the lymph nodes, or after they've gone on hormone treatment, the PSA isn't going down all the way. And then Category 4 would be the people that are truly hormone resistant or have bone metastasis. And then just again to review, our recommendation for treatment considerations based on category is to, for these men, and the rest of our talk is going to be about this topic, Category 2 would be to select amongst these different options based on your perception of which is going to have the best quality of life for you. So you have to do your homework about these things. And of course, you have to shop around to find the doctors that are good at doing it because you get better outcomes. It's been shown clearly. Not all seed implanters are the same. Not all surgeons are the same. And that matters. Category 3, we recommend combination therapy with both testosterone blockade and radiation and possibly a short course of chemotherapy. Category 4, you pull out all the stops, you use everything, combinations of medicines to get the best results. Okay, so we're doing okay for time? I'm going to go on now and, more battery. I didn't think we were on battery. Hopefully not. We are on battery. So the talk is going to accelerate. Shall I hit OK? Will it blow up if I do? I think I'll try it. Okay. All right. According to this computer, we have 27 minutes. Aren't you lucky? Okay, so we're going to talk about active surveillance for prostate cancer. This is a very foreign concept for cancer doctors that have been trained to monitor people for, let's see if we can figure out what who've been trained to treat people. I mean, surgeons, for example, they spend 5 years learning how to cut prostates out. I mean, the idea of not cutting something out is an anathema. So you've got doctors that are not really prepared for the possibility that some forms of cancer don't need to be treated. But prostate cancer is different from other cancers. PSA in particular not only provides for earlier diagnosis, but we also can detect relapses earlier. I was talking about how patients who've had an operation, if the PSA only goes to 0.1 or 2, we can't find the cancer anywhere except we know it's there somewhere. Also, when people go on chemotherapy or hormone treatments, if the PSA doesn't behave appropriately, we know right away the treatment's not working. They don't have this kind of leverage in other cancers. Now, as I mentioned before, prostate cancer is somewhat fastidious in where it's willing to spread, and of course that's an advantage. A lot of cancers, colon cancer, lung cancer, spread by attacking the major organs like the brain and the lung and the liver, killing people. It's very rare for prostate cancer to spread to those organs. It can spread to lymph nodes and to bone, but it turns that those organs tend to be pretty tolerant. And very importantly, that the cancer growth rates with prostate cancer tend to be much, much slower than other cancers, usually measured in terms of months or years for how quickly it doubles, whereas other cancers tend to be measured in days or weeks. What a difference. And then another extremely important point is that hormone treatment for prostate cancer, and you should be aware there are 4 major cancers in the United States that constitute 2/3 of all the cancers. prostate, breast, colon, and lung. 2/3 of all the major cancers are those four. So of those four, prostate cancer and breast cancer have hormone treatments. Lung and colon cancer don't. So we're looking at cancers that you got to give them chemo or it's over, right? And as we know, chemotherapy doesn't always work. Well, the hormone treatment for prostate cancer is 5 times more effective than the hormone treatment for breast cancer. It isn't twice as good, 3 times as good, 5 times more effective than what we have in breast cancer. So prostate cancer is very leveraged compared to the other cancers. So one of the things is we've gone through this staging. We've talked about, why is there so much confusion about what to do? And we've gone through probably the main concern, that there's ignorance about how to subdivide the disease appropriately. But another thing that people don't realize is that this is the only one of the major cancers that is primarily under the management of surgeons, not under the management of cancer specialists or medical oncologists. Urologists are surgeons. And 30, 40 years ago, all the cancers were managed by surgeons. There was no other treatment for cancer except surgery. Radiation was quite poor. Chemotherapy didn't exist. So for some reason, the urologists have grandfathered into this modern era, and medical oncologists to this day at USC are not trained in the management of early-stage prostate cancer. Surgeons do it all. They do the biopsy, and then they sit in that seat of the expert, and they tell people what you need to do. Now, what many people don't know is that they have little experience with other cancers. They have little experience with medical treatment of the disease. They are primarily interested in doing surgery. So surgeons go through an incredibly rigorous program. They spend about 5 years in dark basements cutting out organs, working 36 and 48-hour shifts. It's like 5 years of boot camp. These people go through the most rigorous training in the world, and they have to make immediate decisions when they're in there. There's no, let's do it a different way today, guy. They have these algorithms, just like jet pilots do, that they have to be trained in. And so they're used to thinking of very black and white terms. And as you can see, prostate cancer is anything but black and white. Now, the average urologist across the nation does about 3 radical prostatectomies every year. And radical prostatectomy, the operation to remove the prostate, is one of the most complex surgeries that exist. So we have a real divide between the complexity of this disease and the doctors that are being supposedly trained to handle it, because urologists are doing kidney stones, bladder resuspensions, and potency therapy, and on and on and on, and a little prostate cancer on the side. So there's a real area of confusion that people don't realize, that the urologists are over their heads many times. Now, what is active surveillance? A lot of people confuse it with an old form of therapy that called watchful waiting. So why don't we go ahead and stop here, Lou, then? You want to switch your tape? Saying the active surveillance is, there's an old form of not treating people right away that's been around for 30, 50 years called watchful waiting, and a lot of times active surveillance is confused with watchful waiting because both of these approaches involve no treatment right away. They involve deferring immediate treatment, monitoring. But the differences between the watchful waiting approach and the active surveillance approach are completely different. Now, watchful waiting came about before we had PSA testing. And the idea was to monitor people who were elderly, and they could feel a bump, and they didn't think that the cancer was going to grow fast enough to hurt them within their expected lifetime because they're elderly. Active surveillance, and I'll just read this, closely monitoring selected cancers and withholding curative therapy until there's evidence that the cancer is biologically active or showing some evidence of growth, at which time treatment with curative intent is administered. The idea is to catch the cancer while it's still early before it's spread. And this is a feasible proposition because we're catching cancers so early now that there's actually some space or time that we can use to monitor it. So if we compare the active surveillance newer approach to the older watchful waiting approach, you see the differences are many. The aim of active surveillance is to individualize treatment, so only the men that have a cancer that's growing get treated, and the ones where it's just static, as it is many times, those people can avoid the side effects of treatment. Whereas watchful waiting, the goal is just to avoid treatment as much as possible. It's only done in older people, but with active surveillance, there was a recent consensus conference up at University of California, San Francisco, and they agreed that active surveillance is appropriate for any age. The monitoring with active surveillance is intense because we don't want to have something advance or get missed. But with the watchful waiting, it's kind of accepted that it may spread, and eventually maybe some kind of hormone treatment will be used way down the line, but they don't worry about it too much. Indication for treatment is different. With watchful waiting, historically they've waited for the cancer to get into the bones before they'd start on hormone therapy. Whereas active surveillance, the idea is that if the PSA increases a significant degree, or if some kind of imaging shows cancer growth, or the biopsy looks a little worse, a repeat biopsy down the line looks worse, treatment is started. Therefore, treatment with active surveillance is early, not late, like watchful waiting. And the intent of active surveillance is still to cure people. And with watchful waiting, it's basically just to control symptoms. So why is this concept of no immediate treatment, even in people that do clearly have curable disease? Well, one of the concerns is the fact that PSA screening has been so powerful in showing up all kinds of early stage cancers that we're seeing literally tens of thousands of men that have a type of disease that probably isn't life-threatening. And this gives you an idea of how many men out there that don't know it are walking around with prostate cancer. This is a study in 3,000 men between the ages of 55 to 75 with normal PSA levels. 3,000 men who volunteered to just have a prostate biopsy. Let's go on a fishing expedition, see what we find. No bumps, no evidence that the cancer is rising, just normal range. And what they found, this is with a 6-core biopsy. These days they do 12-core biopsies routinely. So just 6 cores, randomly jabbed into the prostate. If the PSA was between 3 and 4, 1 out of 4 men had prostate cancer in this age group. Okay? Now, how many cancers did 6-core biopsies miss? Okay, so autopsies show that probably the real incidence of prostate cancer, men that die of car accidents and whatever else, not prostate cancer, and then have an autopsy and have their prostate looked at, about 50% of them have prostate cancer. So we're finding this type of cancer now because men have slightly elevated PSAs, not from prostate cancer, but from BPH. You all know that men have benign enlargement of the gland as they get older. Well, that makes the PSA go up, and everyone's worried about prostate cancer, so they all get a biopsy. So we're finding prostate cancer in everybody. And yet we know, I don't know, does anyone here know how many people, if you take 100 men, historically, over the last 20 or 30 years, people die of heart attacks and lung cancer, and some die of prostate cancer. And what do people die of? Well, we know heart attacks is number one, right? But if you had 100 people, normal American males, how many die of prostate cancer? Well, gee, everyone's got it, up to 50%. Must be a lot, right? So anyone want to venture a guess at what's the percent death rate from prostate cancer in the United States? 3%. Yes, it's between 2 and 3%. So we've got a giant divide between how much cancer's out there and how many people are dying of it. Okay? So now you say, well, that's because of all the great treatment. That's why no one's dying, right? Well, the death rates from prostate cancer have dropped since the advent of PSA testing about 15%, 15 to 20%, which is really probably quite an accomplishment because people are living longer and therefore are at risk of dying of prostate cancer for longer periods of time. So to see a drop in the incidence of prostate cancer mortality is quite an accomplishment. But PSA testing has not eliminated the death rate. It has reduced it somewhat. So this difference between the amount of cancer out there and the amount of people or the number of men dying of it is related to the type of cancer it is, not merely because, wow, all of a sudden we solved all the problems, okay? So there's a type of cancer that doesn't appear to be dangerous, and then there's another type that is, and we've tried to go through and give you some guidelines on how to make a distinction between these two things. So I've kind of gone over this concept. The natural history of early-stage low-grade prostate cancer is measured in decades. It's many times, especially these Category 1 men, the disease is very, very slow growing. There are some long-term watchful waiting studies, not active surveillance studies. These are people that were just told that we don't think your cancer is going to hurt you. Go off and come back if your bones start hurting. That's the way watchful waiting was done. And then they would do a orchiectomy, cut their testicles off. That was watchful waiting. So how many people were dying under watchful waiting in that era? Well, there's published in the Journal of the American Medical Association in 2005, in one watchful waiting study, the death rate 20 years down the line was 7%. In another watchful waiting study published in the same journal in 1997, if you picked out the guys that had lower Gleason scores that were on watchful waiting, because they weren't all low Gleason scores, the death rate at 15 years was 2.5%. This is about the rate of men, in the population in general. So even doing watchful waiting, which is a very loosey-goosey way to treat people, the death rates are very low with no immediate treatment. Now, the only reason we're having this long talk is because once they develop a non-toxic way to treat prostate cancer, 90% of all that we've talked about becomes irrelevant. We'll just give it to everybody, right? Just take the treatment, like skin cancer, little freeze or something. Little freeze it again, freeze it 3 times. We can live with that. But the side effects of surgery and radiation and these other things are very notable. So that's fine and good, but if we're going to do surgery and radiation, how much improvement in survival are we really accomplishing? Well, finally, there's one good study that looks at answering that question, and it was a very expensive study done over many, many years in Europe, and they got more than 600 men, I think it's closer to 700 men, to volunteer based on a coin flip who had been diagnosed with prostate cancer to either do immediate surgery or do watchful waiting, not active surveillance. In other words, do nothing. So now we get to find out, does surgery save lives or not? So what kind of guys did they treat? These are typical age prostate cancer patients. PSA was 12.8. This is the average for the 700 men. But some men had PSAs as high as 50 who were treated with surgery or watchful waiting. 20% had PSAs over 20. Now, 1 out of 5 men had a PSA above 20 that was put on this study. In other words, they got on the study, then they flipped the coin, and if it was heads, you got surgery, and if tails, you got nothing. You were watched. 75% of the men had some kind of bump on their prostate. So this was before PSA testing came along. These men were diagnosed because doctors were doing prostate exams and they found big bumps. This is kind of unusual today, right? And 40% of the men had Gleason 7 or higher. 1 out of 20 had Gleason score 8 to 10. So this is basically category 2 type stuff, right? Not category 1. This is category 2 type stuff. But a very well-performed study published in the most prestigious journal in the world, the New England Journal of Medicine. And finally, a well-performed study watched over more than 10 years to determine which is better. Now, how did they handle these people if the cancer started growing, which of course it did in some people? Was it a fair, equal way? Because it's not only what you do right away, but what do you do as time goes on? Do they get treated uniformly? Well, in the surgery group, if the cancer came back where the prostate used to be, a local recurrence, they gave them hormone treatments. If they had cancer come back in the bones, they gave them hormone treatments. In the watchful waiting group, they gave surgery if the cancer seemed to be getting out of control in the prostate but nowhere else, and they gave hormone treatments when the cancer got into the bones. Okay? Now, hormone blockade was not given for a rising PSA. Okay? This is like dinosaur ear treatment, okay? This is unbelievable, but it was done, all right? So you have a real comparison of literally surgery versus nothing, right? So well, one would hope that surgery is going to make a big difference, right? Well, here it is. 10-year survival. Watchful waiting, category 2 men, 85%, nothing. 90% surgery. So 10% of the men had surgery, died anyway, right? 5% of the men who had surgery were better off for having it 10 years later, right? They didn't get their lives saved in 6 months or 12 months. 10 years later, 1 out of 20 men. So here's an analysis. These next 2 slides are a summary of the most eminent active surveillance expert in the world, Dr. Lawrence Klotz, published in the Journal of Clinical Oncology a couple years ago. And he looked at this particular study and did an analysis and said, well, what's going to happen if we extrapolate from this data, and if instead of doing watchful waiting, what would happen if we did active surveillance? And if instead of doing category 2 people, we only did active surveillance in category 1. So this is the study as it was, right? We did watchful waiting, no treatment for a rising PSA, category 2, and 5% reduction in mortality. In other words, you have to do 20 operations in these kinds of people and then treat the non-treatment people really poorly, and you'll save 1 life out of every 20 operations 10 years in the future. Not too exciting. Okay, now, this is the analysis that Dr. Scholz offered. He says, now instead of doing category 2 people, let's do category 1 people. Gleason 6 only, less than a third of cores. No palpable disease. Every man had palpable disease in the other one. PSA is less than 10 and certainly not rising more than 2 points a year. Less than a third of core biopsies. Scans that don't show any spread. And then immediate treatment if there's some evidence of growth, if the PSA is rising, of course, logically speaking. Well, Dr. Scholz did the calculations and said, well, with this better outlook, how many people are going to benefit by having immediate surgery? And his projection is 100 operations are needed to save 1 life 10 years in the future. So 100 men get unnecessary surgery, or 99, to benefit 1 individual 10 years down the line. So, and certainly, when we look at the side effects of these treatments and their impact on quality of life, this is an excellent study published in the Journal of Urology, 2005, looking, an independent researcher went around and queried men that had surgery by other surgeons. A lot of studies that are published about the outcome of surgery are published by the surgeon that did the surgery. And as you can imagine, they sometimes tend to see things with rose-colored glasses. Well, this one was done by a doctor who was unrelated to the surgeons, Dr. Penson. And large study, they gave enough time for men to recover from the operation, and one of the main issues with surgery, of course, is the incidence of erectile dysfunction. And these were the numbers. Before the surgery, 81% were potent, 28% after, all comers. But if you looked at the people that had nerve-sparing surgery, supposed to give you better results, it was age-dependent. So 60% were potent in this age group, ranging down to 18% in men that were 65 and older. This is why people hesitate to do surgery. It's got potential toxicity. What about leaking urine afterwards? Dr. Walsh, the most famous surgeon in the world, reports that 7% of men were still leaking urine significantly a year and a half after the operation. And that's pretty much the gold standard for incontinence. No one has really shown that they can do any better than that. Radiation therapy has its own problems, impotence rates that are comparable, urine burning, and we've gone through this before. But it gives you pause that if you don't need treatment, why do something that could cause this kind of harm? So this is the reason, this study, we're getting near the end now, is Dr. Scholz is the eminent researcher because in the 1990s he saw this coming. And so he started a prospective trial asking men to volunteer to go on active surveillance rather than have immediate treatment. And he used looser indicators than what I'm proposing. Some of his patients did have Gleason 7 disease, and some of them had PSAs over 10. But his protocol was to do a PSA and a digital rectal exam every 3 months, do a prostate ultrasound every year, and repeat the biopsy. Just do a random biopsy after a year and after 3 years. And he found 8 years later, published these findings, I think, a couple years ago, that in this group of men, 423 men, 55% still haven't been treated after 8 years. PSA is not changing, biopsy is no worse, just stayed the same. Now, a third of the men freaked out over time and decided to have treatment, even though there was no evidence of progression. So different people decided to have surgery or radiation, even though PSA wasn't going up and the biopsies weren't worse. 9% did have some rise in PSA that they deemed significant, or the biopsy was worse, maybe the Gleason was higher, or more core biopsies were involved, and those people were treated because they thought it was a kind of cancer that needed treatment. None of the men being followed presently has cancer in the bones, and less than 1% of men have died of prostate cancer. So this, according to Dr. Scholz, now 8 years is not a long time, so that is probably the greatest weakness to the active surveillance arguments in favor. You say 8 years, okay, well that's kind of cool, but what about 15, 20 years? And that is not answered. And that is the reason, however, that people are talking about this before there's 15 and 20-year data is that there are about 50,000 radical prostatectomies being done every year in the United States, and equally amount of number of men getting radiation therapy. So there's a dire need for an alternative, and it appears on paper, not scientifically proven because they don't have 15 and 20-year active surveillance data yet, that active surveillance is going to pan out. So how do you do it? We typically get, like Dr. Klotz, PSAs every 3 months, and what we check is the change compared to previous, and we also look at how high the PSA is relative to how large the gland is. Men are allowed to have more PSA if their prostate gland, not the cancer, the gland is larger. We do a digital rectal exam, we do a color Doppler ultrasound every 6 months. Typically, not invariably, we'll do an MRI up in San Francisco once a year, and we commonly use Proscar Avodart, and I'll explain why in just a minute. The scans that we're talking about are valuable in several ways. The MRI that we refer people up to San Francisco for can identify cancer that was missed on a biopsy, cancer that's coming through the capsule or that's larger than anyone has suspected. So it can highlight potential problems before they happen. It also, perhaps most importantly, can look at the size of the tumor before and compare it over time and determine if the dimensions are enlarging and if the cancer is growing. In my experience, men that have cancer that's growing are detected first with scans before PSA goes up, because a lot of PSA in these early stage men comes from the prostate gland, not from the cancer. These are very tiny cancers. So finding out the size of the prostate is important because the PSA density has to do with the ratio, as I said before, between how big the gland is and how much PSA there is. But if you don't know the exact size of the gland, how can you determine that? So you need an MRI or, of course, an ultrasound to find that out. Now, color Doppler ultrasound basically does all the things that MRI does, identifying favorable lesions, measuring the tumor progression, determines the size of the prostate. But in addition, it's quite a bit more convenient. We're talking about a 10, 15-minute study rather than an hour with a probe up your behind. We're talking about something that can also look for increased vascularity, which is an indicator of higher grade disease. And perhaps most importantly, with color Doppler ultrasound, suspicious lesions can be needle biopsied to determine what's going on, where you can't do that with an MRI. So MRIs, you see shadows and spots, but you're never 100% sure with just MRI testing if it's a cancerous spot or not, whereas with ultrasound followed by biopsy, you can be sure. I think this might be getting near the end here. Now, Proscar or Avodart, two very similar substances that block dihydrotestosterone. This is the type of testosterone inside the prostate. There's a different type of testosterone inside the prostate, and that is advantageous because it allows us to administer substances that don't dry up testosterone throughout the whole body. Most of you are probably aware, as we've talked about, that blocking testosterone inhibits or reverses cancer. Well, wouldn't it be nice if we had something that could only inhibit testosterone inside the prostate? And that's what these substances do. So it's been shown in a very large 10,000 member randomized prospective trial that men that took Proscar for 7 years compared to a sugar pill, and who were all biopsied, had a 50% less incidence of cancer than those that were taking a sugar pill or a placebo. So it suppresses cancer growth. Not surprisingly, we know that hormone treatment suppresses cancer growth, and these substances, so you've probably seen Avodart advertised on the TV, to shrink the prostate gland. So this is not FDA approved to treat cancer, it's FDA approved to help men's urinary symptoms. And that's, of course, one of the advantages. It improves urinary function. But it's not yet FDA approved to treat cancer, therefore they're not allowed to talk about that. But there are a number of studies going on, and of course with Proscar, it already has been studied, and these things work almost identically, not identically, but almost identically. And so we can be quite confident that the effects we see with Proscar will also occur with Avodart. So, well, that's marvelous. It suppresses cancer growth, but there had been questions about, does Proscar or Avodart mask PSA? Does it mask cancer? Because we know that it lowers the PSA. Remember, the old standard way of doing PSA testing was to go to the doctor, have the PSA done, and as long as it was less than 4, oh, you're fine. And there was no consideration given to whether it had been steadily rising over time. So they just looked at the thing. They didn't look at how big the prostate was. If it's above 4, you got a biopsy. If it was below 4, you didn't get a biopsy. So when the PSA was lowered by these agents, there was a concern that men are going to have cancer growing, and you won't see it because the PSA won't get above 4. Well, in the large study that was done, it was interesting. They finally found that what it does, rather than masking cancer, if you use the change in PSA over time, not just some arbitrary cut point like 4, but if you look at what the PSA is over time and if it's rising, people on these agents have a more accurate indication of the presence of cancer because these things take away the benign PSA, the background noise from the gland. So PSAs will drop lower, and if the PSA starts rising on these substances, that's a greater concern. And this was actually proven in the large PROSCAR study where they found a much higher incidence of high-grade cancers in the people on PROSCAR compared to the ones on placebos. So the PSA went up a little bit, people got biopsied, and they were diagnosed earlier, not later, earlier than the people that were taking the placebo pill. So it improves the accuracy of PSA. It doesn't mask cancer. It does the opposite. Suppresses cancer growth, improves the accuracy of PSA, FDA approved to help men's urinary flow, and by making prostate glands smaller, if people have a random biopsy, it's easier to find cancer. If you have a big prostate and you give 6 cores or 12 cores, you've got more territory to cover. These medicines usually shrink the prostate about 30% in size, bringing it down, and therefore, if you do a biopsy, you're more likely to find cancer because the target is smaller. Now, what's the price of admission in terms of potential side effects? About 1 in 10 men will say that their sex drive is dropping off, in which case we just stop it. This is not an essential component of active surveillance. The side effects go away when you stop the pill. Maybe 1 out of 100 men will notice some breast tenderness or early breast enlargement. You just stop the pill. The prostate makes semen, and so by reducing the size of the prostate and reducing the activity of the prostate, many men will notice less semen with orgasm than they did previously. Now, those are the medical interventions that we routinely recommend for our men on active surveillance. What about lifestyle changes? I mean, are there other things that we can do to keep that little tiny cancer from growing into a problem someday? Well, I hope you all do come to the conference a week from Saturday. I was going to be speaking on this topic on Saturday morning, but as I was going through it, a lot of this talk was turning out to be a talk about the power of diet to inhibit cancer growth. And as I was going through my preparations, I found out that I was almost parroting a book by Colin Campbell called The China Study. Colin Campbell is probably the preeminent diet expert on cancer in the world. And I don't even know if there's a close second. His book, The China Study, is a publication for lay people that summarizes a lifetime of work and millions, literally, I think more than $100 million worth of research that was spent on trying to determine the effective diet on cancer growth. The bottom line is that he found out that vegetarian or vegan diets have a dramatic inhibitory effect, not only on prostate cancer, but all cancers. And he's going to be speaking at 8:30 on Saturday morning. I would suggest you try and make that talk if you don't miss anything else. If you can't make it, get his book and read it, because the impact of diet, for example, in China, they have just as much low-grade prostate cancer as we do here in the United States. The mortality rates from prostate cancer in China, where they more commonly eat vegetarian diets, 20 times lower. Not as half as much, not a third as much. 20 times lower than it is here in the United States. And then if you move the Chinese over here, guess what? And they start eating our diet, they start getting prostate cancer mortality that starts to match ours. Just one example of some of the information in the book. Another very important thing is most men with prostate cancer are over age 50, many over age 60. There was a very important study performed, and I've mentioned this before in talks, published in the New England Journal of Medicine, that just looked at men who, how far could they go on a treadmill? Men and women, actually. I think there were about 10,000 people in the study. These people had no known heart problems, no known illnesses, and in this study that was published, they just put the people on a treadmill, and said, go as long as you can, and when you can't go any longer, stop. And then they measured how strong were they, how long did they last, and divided them into 3 groups: the strong, the average, and the weak. And this doctor had a very simple formula. He just went to the Social Security database 10 years later, punched in their Social Security numbers, and found out if they're still collecting a check or not. He assumed there'd be very few people alive that weren't collecting a check. And that assumption was accepted by the New England Journal of Medicine. And what they discovered is that the top group, the fit group, 90% were alive 10 years later. The unfit group, the bottom group, 60% were alive. These are totally healthy people, no heart disease, no illnesses. Immense difference in 10-year survival just based on fitness. The intermediate group was right in between, 75% 10-year survival. So one of the things they pointed out is that it was more dangerous to be unfit than it is to smoke. So you're better off working out and exercising and being a smoker. You're more likely to live longer than if you don't smoke and just sit around. It's more dangerous to be unfit. And these are the old standbys. I'm not going to spend much time talking about it. Dr. Myers has a whole talk of this at the conference. These things, I believe, are valuable. They're certainly non-toxic. Particularly vitamin D appears to have an inhibitory effect on the growth. It seems to slow the growth of all tissues and all cancers, including prostate cancer. Of course, it also has an effect on the bones. So it improves osteoporosis, which one little data that people often forget is that 1/3 of hip fractures in the United States occur in men. So the idea that osteoporosis is a female disease is ridiculous. And the mortality rate of hip fractures in men is 50%. So men that have a hip fracture, about half of them die of it. So looking for osteoporosis, a very simple thing to do, a very simple thing to treat, is a critical and obvious thing that all men should be doing. So, conclusions then. Aggressive, hurried treatment, benefits, very, very few men in this category 1. The window of opportunity to defeat early stage disease is measured in many years, not months. Active surveillance rather than immediate radical treatment allows the majority of category 1 men to safely avoid the side effects of being cured for many, many years, if not indefinitely. So I'll go ahead and take some questions now. Do we want to turn the lights on? All right.
In this area, that will take tumor tissue and test it in terms of which type of chemotherapy agent would act best. Do you ascribe to that procedure, or would you comment about that?
It's called chemosensitivity testing.
Yep.
And the physician that is probably the most preeminent in this is down in Long Beach, and he's a very good medical oncologist. And the chemosensitivity testing is an art form, and I believe that he is probably state-of-the-art in doing it. So if someone wants to do it, I believe that the doctor in Long Beach is a good place to go. One thing, though, that's a limitation of that question is sometimes it's difficult to get cells for testing. It takes some time to do it, so you're delaying therapy while you wait to get the results. And we'll often find that the results validate what we suspect would have been true anyway. In other words, there weren't that many active chemo drugs on that list. There was Taxotere and Avastin. And so if you have someone that's in a situation that we're worried about, we usually just jump in with the active agents because the chemosensitivity testing usually just validates it. So I have used it a few times through the years, and maybe once or twice it helped after we'd been through 2 or 3 treatments and we didn't really know what to do next. But it's not something we've used very commonly. So it's one of those esoteric things, I guess is what I'd say, that there may be a place for it. I have not ordered it, I don't think, a single time in the last 3 years, but on occasion it does come up.
The second question is perhaps a little preview of the forthcoming conference. If you had a family history of both prostate cancer and heart disease, what supplements would you take?
Well, of course, I advise people that diet is 10 times more powerful at changing your future than any supplement is. Diet and exercise. The supplements, and when you look at single agents, you'll see that it takes very, very large studies to see very small effects. But since the supplements like lycopene and selenium are thought to be completely safe, we do recommend that they be taken. So we've got a fairly short list of supplements. The supplements for heart disease that we keep it as short as we can. We don't want someone to die of choking on a pill, right? And people are always adding other things that they want. But the things that are heart-related on our list are fish oil, and for people that are taking statin drugs like Lipitor or Zocor or Crestor, we recommend coenzyme Q10 because it's known that those substances can deplete coenzyme Q10 from your muscles. So those are the only heart-related ones. There are some herbal substances that we've kind of put in the iffy category, curcumin, modified citrus pectin, and trying to think what else we have on our list. But it's not a very long list. We usually beat on people to try and follow a good diet, and then a limited number of supplements in addition. Yeah.
Do you know of any significant difference in side effects and cure rate, whatever, on the proton as opposed to the standard radiation?
Yeah, proton, what I summarize with proton was a major technological advance for the 1990s compared to the old four-field techniques. I don't think it competes very well with IMRT because while proton argues that they can stop the beam at the far side of the prostate, they don't argue that they can curve the beam around that curved target. It's a square beam that goes in, so you have overshoot on the corners there. IMRT can curve the beam around and conform it. And I think this explains the reason that even though proton showed a reduction in rectal burn rates, which is really the issue with beam radiation, is always rectal burn rates, showed a very substantial reduction in rectal burn rates, it doesn't match IMRT, which is down to about 2 to 4%. From my sense of reading their literature and whatnot, it's not quite as good. Now, to validate that, when you talk to Carl Rossi, they are actively developing IMRT for their proton machine. And so they think they're going to have that out in about a year, and I think when they do, they're going to have something very special. Right now, we're pushing people more towards IMRT.
How about IMRT as opposed to the IGRT? Is this really a good advance?
I think that the IMRT and the IGRT are very, very close to each other. I cannot distinguish a difference in terms yet because the rectal burn rates are so low, you're going to need huge studies to see a difference between these two different approaches. So more important is the experience of the doctors that are doing it. When you're shopping for an IMRT doctor, you have to realize it's not just the doctor, it's his physicist, it's his equipment, and it's his technicians. Many times the radiation therapist is only seeing you once a week, and he signs everything up, but it's really the team that he's pulled together that's going to determine how effective and non-toxic the treatment is.
One last thing that came to me just today, I'm really big on this diet thing and have been for some time, but somebody here had something like, in a document that said cesium was the greatest thing since sliced bread. Mm-hmm. Do you know of anything that you could tell all of us in our diet, since diet is very important, mm-hmm. that we might not be thinking of? Is there anything like cesium? I would never have thought of that. But is there anything that we should add to our diet if we're not doing so at this point?
Okay, most of the leverage that we are seeing now with the recent research about diet is what we're taking away, not what we're adding. It's the absence of animal proteins, absence of fats, these sorts of things that are making the huge difference that are being seen in these diet studies. There are a few bad actors. Every now and then, Dr. Snuffy Myers pointed out to us a couple years ago that there's some studies that suggest that chondroitin sulfate, a commonly used substance for men with joint problems along with glucosamine, that there were some animal studies showing that chondroitin seemed to stimulate cancer growth. So staying away from chondroitin would be something that comes up frequently. But it's usually not the magic supplement. It's more just the day-to-day diet stuff. Yeah.
Dr. Scholz, thank you for an excellent presentation here this evening.
Oh, you're most welcome.
My question is, you used a 0.5 PSA and suggested, as I recall, in one of your charts, that if the PSA was under 0.5 in terms of active surveillance, that would be a good indicator. Are
you referring to that biopsy slide where you
Yes.
saw the breakdown?
I think so.
that was a slide for your memory. Remember, they biopsied 3,000 men who had normal PSAs below 4, but they broke it down by 3 to 4, 2 to 3, and whatnot. And the lowest group, the ones that had PSA less than 0.5, had only 6% incidence of prostate cancer. The point of this slide was not that people with really low PSAs are better off. The point of the slide was that there is so much prostate cancer out there that we better rethink about how dangerous it is. If all those guys out there that have normal PSAs, if they have prostate cancer too, I mean, it has to argue that it's not a very dangerous disease, whether you're in the 0.5 or now, it is important because we know a small percentage of them over time will turn into a problem. So it doesn't argue for not watching them closely, right? But it does argue for not just jumping in and treating every single one.
Would you happen to know what the rationale would be for selecting the 0.5? Was it a statistical factor, or was there some?
Well, maybe are you talking about the other slide that if your PSA didn't drop below 0.0?
I don't recall the slide.
There was another slide that when people went on TIP or testosterone blockade, if their PSA didn't get below a threshold of 0.05, they had a very, very dangerous outlook over the next 5 to 6 years. It was selected basically by looking at the data and looking for a natural cut point. And the people that came in higher than that. Now, originally that was selected because the assays in the early 1990s, when we started collecting data on that sort of thing, didn't go below 0.05. So that was as low as it went. It was interesting when more powerful assays came out, which now measure down to 0.003. We were really wondering if that lower measurement was going to reveal new information about long-term outcome. Maybe it's even better to go below 0.01. Maybe it's even better to go below 0.003. But we didn't see that. If people got below 0.05, that they seemed to do well, and when they didn't, they seemed to have a lot of trouble. Yeah.
Active surveillance involves repeated testing, biopsies, and scans. And I'm curious, has the insurance industry come along with this, and are they generally receptive to this type of approach?
Yes. We have not run it. For all the things that I've described, I have not seen any problems with insurance reimbursement. The only exception would be is the MRI done up in San Francisco has a component called spectroscopy, which is a new ancillary addition to the MRI that makes it even more accurate. It's a nice little component. That is typically not covered by insurance and we send our patients up to San Francisco for this study, so traditionally they've sort of comped it. They've been very generous with patients. They'll try and collect the money, and if it doesn't work out, but there is no Medicare reimbursement for the spectroscopy portion of the endorectal MRI. Everything else is covered. ProScar and Avodart may or may not be covered, depending on whether or not you have a prescription program, right? But everything else has been very good. Yeah.
I have 3 points. Last week I visited my primary caregiver to review my cancer situation, and he, quickly stated that he would go into robotic surgery. I've heard of robotic surgery, but not pertaining to prostate surgery, and he was referencing out at the City of Hope. Why would robotic surgery be better than regular surgery?
Robotic surgery has, assuming that you have a doctor that's very experienced in doing it, studies show that it takes about 250 practice cases to get as good as you're going to get with robotic surgery. But the people at City of Hope have more than 250, well more than 250 under their belt. Mark Scholz will be speaking at our conference. He's going to be talking about robotic surgery. The advantages of robotic surgery are that the incision is smaller, and therefore the healing is more rapid after the operation. Unfortunately, the studies that have been published so far, and City of Hope has not published any studies to this effect, so we don't know. They claim things are great, but who knows? That the incidence of the real problems that we're concerned about, not an extra couple days in the hospital, but impotence, incontinence, and penis shrinkage and all these things are identical to the old way of doing things. So robotic surgery has the advantage of a smaller incision, go home from the hospital quicker, and recover quicker, in my opinion. People are back to work sooner. Unfortunately, no evidence of any sort at this time that there's a better outcome with impotence, incontinence, and the things that really matter.
Are you going to show conclusions for treatment on Category 2?
Well, remember, Category 2 involved discussion
Like the
of...
same, you have a summary there. I was just wondering.
No, I'm going, I didn't have time. I tried to spend some time going on the quick pros and cons of the different options. But the talk, and those things are usually covered extensively, surgery, radiation. This is a newer concept that people are pretty unsure about.
Lastly, I've been sort of very positive on this prostate cancer that, I'm going to get it taken care of and I'm going to get well. And all of a sudden I heard about Merv Griffin dying from prostate cancer. And I got to thinking, here's a guy that's got billions of dollars that can spend and have any possible treatment in the world. Do you have any background knowledge of what?
No, I don't know his clinical care, but one of the take-home messages of the talk tonight is that not all prostate cancer is created equal, right? And it's important to do your darndest to try and figure out what category of prostate cancer you have. I don't know his case, but I can almost guarantee you that he didn't have Category 1 disease when he was diagnosed 10 years ago.
One last, for those that are new to this meeting, I was here a month ago and purchased a book on the primer for prostate cancer. If you have not read the book, and it's only $20, I read it and was totally understood what the doctor was talking about tonight. It's well worth getting it. And this is unsolicited, but it's a good book to have.
Evening, Dr. Scholz.
Evening.
Enjoyed your presentation very much. Proscar versus Avodart. And Dr. Bob was here about 6 months ago, and he kind of said they're going back to Proscar from Avodart.
Mhm.
Can you talk about any experience or
Sure.
evidence you have so far as to which is more
Yeah,
efficacious?
it's an undisputable fact that Avodart lowers DHT in the blood better than Proscar. However, Proscar was the study that I quoted to you where they looked at 10-year outcomes. That wasn't Avodart, that was Proscar. So the one where I showed you the study where Proscar inhibited cancer growth and it detected high-grade cancers better, all that was a Proscar study. The assumption is that Avodart, which lowers DHT better than Proscar, works at least as well, maybe even better. However, that's an assumption, not a scientific finding, right? So I don't think anyone's ever going to test the two head-to-head, and we may never know the answer. But my general sense is that it's at least as good. The argument in favor of Proscar could be that the Proscar has some other unknown mechanism of anti-cancer effect that Avodart doesn't have. That's how one would determine that. I have no idea.
But it does reduce more DHT.
Avodart, we've seen it with our own eyes. We'll check DHT in patients, and if it's not fully suppressed with Proscar, when we switch to Avodart, the DHT almost always drops lower in the blood. Now, it's the DHT in the prostate we're worried about, right? But we can't measure that. So we're assuming that lower levels in the blood is good. I mean, that seems like a reasonable assumption, but it's really the levels in the prostate that count, and it's never been proven that Avodart works better. There have been studies showing that Avodart does lower DHT, dihydrotestosterone, in the prostate. I mean, that has been established, but there's no comparison between the two that I'm aware of.
Thank you. In terms of vitamin D, could you talk a little bit about dosage, and do you recommend taking calcium with it?
Well, we recommend calcium usually based on bone density findings. If people have robust bone density, we don't routinely give calcium with it. Vitamin D levels, we're living much longer than previous generations, and we know that the skin doesn't convert sunlight as well as it does when we're younger. We also know we don't spend as much time in the sunlight. In fact, sometimes we try and stay out of the sunlight. And it is a known fact that vitamin D inhibits cancer growth. So it's generally felt that the population at large is mostly vitamin D deficient, and that the typical recommendations of 400 or 800 units a day is grossly inadequate, and that doses of 2 to 4 or 5,000 or more would probably be more appropriate. So I would recommend that you speak to your physicians and have your vitamin D levels checked, and in my experience, more than half the time the vitamin D levels are lower than what we would consider optimal, and vitamin D does an awful lot of good things. Strengthens bones, inhibits cancer growth, prostate and other cancers. So that's a very hot topic right now and very important question. Yeah.
And you mentioned coenzyme Q10.
Well, I
What's-
mentioned it in the context of people taking cholesterol pills, that you're probably all aware that cholesterol pills on occasion cause some muscle problems, and some people can't take cholesterol pills or statin drugs, not all cholesterol pills, just statin drugs, because of the muscle problems. And one of the reasons they believe is because it depletes coenzyme Q10 from the muscles, and that the restoration of coenzyme Q10 will reduce the risk of that problem. So,
Thank you.
mm-hmm.
Yeah, I have a caring daughter that sent me a book from Texas where she lives, written by Patrick, I think it's Patrick Quillen and his wife, about how to beat cancer with nutrition, and not to say that entirely with nutrition. They approach it from the aspect of supplementing and enhancing the oncology treatments. And the one thing I do remember that surprised me was it says that cancer cells feed on sugar and dairy products, or the result of dairy products.
Right.
Would you want to comment on that?
I agree. Yeah.
Well, the second one is a delicate subject. If the oncological treatment has suppressed the PSA, is artificially suppressed to some extent? Am I not right?
I'm sorry, I lost you. What artificially suppresses
well,
PSA?
Cancer patient who has PSA, let's say of 4 or 5 or 6, whatever it is usually artificially suppressed if you go into hormone deprivation.
Mm-hmm.
So whenever you complete that, it's going to maybe return to some degree.
Mm-hmm.
Usually it's undetectable almost immediately.
Mm-hmm.
And it stays that way as long as you're on the treatment. You go off the treatment, you've completed it, it's going to rise somewhat, and sometimes more than others. But what's the take on if you would then, it also has suppressed testosterone, which in older people is pretty low anyway. There's a merit of raising the testosterone. What effect, is there an effect of that in assisting in controlling the PSA?
You mean, does giving extra testosterone lower PSA? Is that your question?
Well, it won't lower it, but does it play a part in controlling it, not having it rise?
Not in my experience.
Thank you, Doctor, for sharing your time with us. 2 questions. First, you mentioned IMRT. Can you comment on the difference between that and tomotherapy?
In the experts that I've talked to in this area, the differences are very. Someone mentioned IGRT. It seems that it's 6 one way, half dozen the other. It's going to be more important the doctors behind the steering wheel than the type of equipment they're driving.
And also, could you comment, or do you know about a clinical trial that's being done at Rockefeller University in New York on dendritic cell vaccines for prostate cancer?
Are you talking about the Provenge study? Is that what you're...
No, it's a Rockefeller University clinical trial, stage 1-2, dealing with dendritic cell vaccines.
Well, that's what Provenge is.
It is a Provenge?
Yeah. The Provenge appears to have activity, not, barn-burning activity, but certainly, remember, the testing was done in very, very sick men. So the hope is that when finally gets FDA approval, that the dendritic cell vaccine will have greater activity in people that haven't got one foot in the grave. And that's not a proven thing, but there is one study by Eric Small where he gave dendritic cell therapy to men with rising PSAs, and it did inhibit PSA rise in a significant percentage of people. So the reason the dendritic cell therapy is attractive is because the side effects tend to be minimal. So even if it didn't work in every single individual, if you're the lucky guy that it does work in, wonderful. If you're the bigger number of unlucky guys that it didn't work in, you're probably no worse for the wear. So it's one of those things that as long as you don't have rampaging disease, that most men have time to try stuff. And if it works, marvelous, and if it doesn't. I think that the future of the immune treatments is going to be built on foundations of treatments like that. When treatments don't have very many side effects, the possibility for combining them exists. It's the side effects that limits our ability to combine treatments. It's just people can't take it after a certain point. But when you have these relatively non-toxic treatments, you can add them together, and it appears that the big breakthrough, it's amazing, all the alternative medicine docs have been hawking immune supplements for years, and the reason they do that is because you can't prove it doesn't work. So they can say anything and sell anything. But it looks like that the breakthrough, is it going to be magic treatments? Is it going to be some, super drug or something? It looks like it's going to be methodology to stimulate the immune system, probably within the next 5 years, maybe 10, that's going to just turn not only prostate cancer around, but all cancers. Yeah.
I have a few questions. You mentioned proton therapies earlier. What do you know of neutron therapy?
Well, there's only a couple centers that use it. We use it in particularly refractive cases where the tumors are very large. Like most treatments, radiation doesn't work as good when the tumors are big. It works better when there's less cancer to kill. You could pretty much say that about almost any treatment. So one of the advantages of neutrons is that they're heavier particles. It's like the, what are they, plutonium bullets that the tanks fire over in Iraq. So there's more hitting power with neutron therapy. But at this point, I don't think the future is going to be with that sort of thing, because the photon therapy with IGRT, tomotherapy, IMRT, is getting very high cure rates already. So it's almost, and we're not seeing the really big gross tumors that we used to very frequently. So I think that it's, and I'm not aware of anyone that's doing IMRT with neutrons, which is
Pure neutron that they do?
Yeah.
Do they do mono combination or what?
I'm not aware of
specifically of Fermilabs and things like that.
Right, yeah. I'm not aware of all the different potpourri of options that they're offering at Fermilabs. But the last patient we referred to them for neutron therapy just got pure neutron therapy. So, but they don't have the targeting techniques.
Let me ask you about the collateral damage involved.
Yeah, you see, radiation involves delivering sufficient treatment to the right spot. And unfortunately, Fermilabs does not have the targeting treatment that we've been talking about, like TOMO and IMRT and this sort of thing. So even though they've got a plutonium bullet, they don't have as good a sight.
Earlier you mentioned several diagnostic methods such as Doppler, et cetera, but you didn't say anything about prostate scan.
Prostate.
Prostate scan.
Uh-huh.
What do you think of prostate scan as a diagnostic tool?
I didn't mention it.
Is there a reason why you didn't mention it?
Yes, there's a reason to everything I did tonight.
But you won't state what the reason is.
Very inaccurate.
You believe it is inaccurate compared to the other methods?
Yes.
Okay. And the last question I have is regarding pomegranate juice.
Mm-hmm.
They say your PSA time is lowered when you drink pomegranate juice. Is this a masking device, or is it actually reducing the chances of...
No one knows, but historically, anytime something has shown a positive effect on PSA, when they have the luxury of some kind of testing on other measures like relapse rates or spread to the bones or mortality, it has always proven to have some predictive power in that sense. So this whole idea of masking that I'm aware of has not been ever shown to be misleading people. Now, I'm talking about in studies where they have big groups. In any one individual, PSA can certainly mislead people. Okay? So that's why we never relied just on PSA for guiding people's lives through the prostate cancer minefield. You do scans, you do physical exams, you check other blood tests, you talk to people, and you form an overall picture of what's going on. PSA is probably the most important component, but now and then it will completely mislead you, and people get their fingers burned when they put all their eggs in the PSA basket. So now pomegranate juice is on our list of that short list of supplements, but there's really only one study that shows it's got activity, and so it's yet to be validated by an outside center.
I want to ask a question about luprin. I think it's been studied and shown that it reduces the cancer cells, puts them in remission. But what are the negative aspects of using Lupron over a long period of time and affecting the total body?
Well, I had a whole list. There was about a dozen things, and in the interest of time, I usually summarize the top 3 things that concern people: loss of libido, loss of muscle strength, and weight gain. Those are the most troublesome aspects when you're being managed by an expert, because the other problems, breast growth, osteoporosis, anemia, those can all be corrected with medical means. But the hard things that men wrestle with are strength, libido, and weight gain. Those are the hardest things.
So you're saying, to your knowledge, it doesn't affect any other aspect of the body?
Say that again?
To your knowledge, it doesn't affect any other aspect of the human body?
No, I didn't say that. Did I say that? I didn't think I said that. I said there's a multitude of effects. Most of them are correctable if you counteract them with appropriate medical care, and some of them are more difficult, such as weight gain. We don't have a pill for that yet, right? So, no, I could give 3 talks on the side effects of hormone treatments, but that, I'm not. Maybe there's some place you're going with this question that I don't understand.
No, I'm just asking if there are any long-term effects that are quite harmful to the body using Lupron.
There are people that are mismanaged, that don't take preventative measures. They can get osteoporosis and hip fractures and spine fractures. That's a pretty nasty one. People can develop shrinkage of their penis if they don't take Viagra or Cialis on a regular basis. They can develop weight gain, diabetes, and have hardening of their arteries. Yeah, there's lots of scary things that can happen.
Okay, so diabetes, you mentioned something else just now besides diabetes?
I have several articles that are written on this. If you want to go to my website, they'll enumerate all the side effects and what you need to do about them.
Right. Would you recommend a person be on Lupron for an extended period of time, a few years, several years, as opposed to other treatment?
Well, what's my question going to be? What category of cancer do you
sorry, category 2.
have? Okay, now we're getting somewhere.
Okay, sorry.
For category 2 patients, we recommend 12 months of treatment if they decide to do that rather than surgery or radiation, which are other options, and then repeat biopsy. And if the biopsy is clear, we recommend stopping the treatment after 12 months.
What is the reoccurrence of the cancer after you stop?
Well, historically, when we didn't do biopsies, when we didn't call out the men with persistent disease, about 1/3 of the men never needed retreatment. About 1/3 had their PSAs come back within the next 2 to 4 years, and they needed another treatment early on. And 1/3 of the men had a slow return of their PSA over 4 to 10 years and needed some kind of treatment in a delayed sense.
In the second group, the return of treatment, was this go back to Lupron or something else?
It was, they had the choice, of course, but many of the men that got only short holidays on Lupron said, gee, that was an awful brief time. I think I'll consider trying something different. So many of them went to radiation or seed implants. That's what happened in my practice. But we offer them all the options.
Do you feel that Lupron can be a cure or a near cure without going to seed or surgery?
Yes, on occasion it certainly is. I presented a particularly shocking cure early on in the talk. A man that had a rising PSA after surgery with Gleason 9 was treated with 12 months of treatment back in 1992 or 93, I can't remember, and his PSA is still 0 today.
Thank you.
Yeah.
Do you have any experience with CyberKnife?
I'm not a radiation therapist, but I have referred patients for CyberKnife. Yeah. Most of those patients were not treated in the prostate gland. They were patients that had isolated spots of cancer somewhere else in their body that we referred for CyberKnife treatment, like maybe one spot in the bones or one lymph node, and that was the context we used it. CyberKnife will probably work for treating the prostate as well, but since the other forms of radiation, they've worked the bugs out of it a lot more, and we have an idea of what people are getting into, whereas with CyberKnife, treatment to the prostate has been very limited. So we haven't been referring for CyberKnife for primary prostate cancer treatment